ASHA guidelines for pediatric hearing assessment include behavioral observation of the infant or child, a thorough case history and parental report, physiological development, and objective measures that include otoacoustic emissions, which we just talked about, and tympanometry, so testing the middle ear. So you want to look inside the child's ears. They always hate this. You want to try to do OAEs because OAEs are objective tests. You don't necessarily need the child's cooperation, but remember they can't determine a mild hearing loss and they only test up to the cochlea. Then you have tympanometry to help evaluate the middle ear, but tympanometry cannot be performed on neonates or infants because their ear canals are too flaccid. There are also acoustic reflexes, which are used to help determine if a sensorineural hearing loss exists. And then there's pure tone audiometry and bone conduction audiometry. This is if the child is old enough to participate in these tests, which helps determine severity and the type of the hearing loss. Objective tests mean that the subject does not need to be involved, so they just need to sit quietly. They include tympanometry, the test of the middle ear, OAEs, the test of the cochlea, and ABR, the test of the brainstem, and they're performed by placing a probe in the child's ears. It's difficult to do these tests if the child's crying, vocalizing, or their background noise. Because these sounds are really soft, these measurements are really low, we need the child to sit quietly. And usually you need two audiologists, one to distract the child and the other to perform the test. When you're testing children from birth to 2 years old, it's important to first observe the child, their relationship with adults, their gait, their walk, their standing position, their motor performance. How is the child, the infant, communicating, gesturing, pointing, vocalizing? Is everything age appropriate? Are they following along the growth chart? You can check children by seeing if they respond to sound or calling their names, noisemaker, bells, rattles. So even if you can't get a full evaluation, if you say, "Hey Johnny," and Johnny looks over at you, that's a good sign. So stress is made on using meaningful sounds. You're always going to have two clinicians when you're working with an infant or a child. One clinician sits in the booth with the child and the other does the testing. And the clinician in the booth will be wearing a headset so that she can communicate or hear what the clinician running the test is doing. Whether the clinician in the booth needs to keep the child quiet or keep the child on task. You need two audiologists when testing children. Localization is very important for testing kids 6 months and on. Localization is turning or orienting to a sound, and it's important for pediatric testing. With auditory localization, it really comes together at 6 months. Around 3 months, an infant's able to hold their head up and move horizontally to a sound. At 5 months, they can localize in a straight line, first horizontally, then vertically. At 6 months, their head and their eyes move in an arc towards the sound, and by 8 months, their eyes and their head move directly to the sound source. Localization is very important when we're doing visual reinforcement audiometry, which we'll talk about next.